Madam, it's all yours.
Good evening, everyone. We welcome you all to the third chapter of Season 2 of Youthful IRSI. After a successful physical chapter in the annual UKSOS conference and the South Asian Academy of Ophthalmology, we are back again this month with a very important virtual factor. Running your practice successfully is almost impossible without knowing all the nuances, headaches, and everything that goes in starting your practice and running it smoothly. To help setting up your practice easier, we are here to solve that problem and the queries with the building blocks of ophthalmology. How to set up your OT, what all is needed for that setup, what is the basic infrastructure that is needed, how do you become a team leader, how do you incentivize your staff, how to smoothly run your practice, and all of this more will be discussed today with our esteemed panelists. I recommend Dr. Himanshu. I welcome Dr. Himanshu Mehta, past IRSI president, to please give his initial thoughts on this topic.
Good evening, friends, and thank you very much, Dr. Senthil, Dr. Saurabh, and Shreyas for joining in for such an important session.
Thank you. Thank you.
And thank you, Rohan and Pooja, for inviting me. I guess it's one of the major thing which medicine does not teach. Medicine does not teach you too much of team building, economics, finance. But what I'm showing behind is that even when you're doing mountaineering or the Navy SEALs, if you follow some of those good American movies, you will realize that Navy SEALs never go alone. There's a team. There is always a team. And the biggest thing that most people, the smartest of the people tell you is how well can you find your own team members and build your team. When you're being funded, even in Silicon Valley, they don't take a solo founder. If you have a friend, you have a second co-founder, your chances of getting your funding from the VCs and the Ps is way better. So also in life, we all know that very well, that building a team, getting the whole thing going, each one has its own USP. Bring across the table, we agree to disagree on quite a few points, and we agree to agree on many points. But that's where the whole team would be very much made for. As we realize gradually in life that the game of chess, the rook has its own value, each of the members in the whole game has their own value. And each has a specific role to play. And so also if we realize that who's for the right role, you might have taken an employee for an X particular thing, but you realize gradually that he's way better in something else. That's exactly where they belong, and that's how we can make a team. And it's so very important for a smooth functioning of the whole thing, because the moment from getting the patient, registering the patient, the whole delightful experience to the surgery and the aftercare, it's all a part of the team building exercise. I think we are looking forward to listening to some very great pearls of wisdom from all the speakers whom we have got. Thank you all very much for inviting me and everybody participating. And this Youthful IRSI has gone into a great mode. Everybody has acknowledged it and everybody has loved it. Each one of them is being invited, and it's a great contribution, and this is there on record for the rest of their life for young people when they are starting their career. When we started our careers, we had nothing to look back or fall back to. Yeah, Saurabh, what did we have?
We had very limited opportunities, and more so you would have less than what I got.
Yeah, so you just started with trial and error, and you didn't know what's going on in life. So well, looking forward to some great pearls of wisdom. Thank you so much.
Thank you so much, sir. Now, without further ado, I would like to welcome our first speaker, Dr. Shreyas Ramamurthy. He's a consultant to cornea, cataract, and refractive surgery at the Eye Foundation, Chennai. He's been awarded a gold medal for outstanding contribution in a subspecialty at IRSI. He has 22 major publications in peer-reviewed journals. We have him here to talk about the main aspect of setting up a practice, the brick and mortar story. So he's going to be talking about the proper infrastructure part of ophthalmology. Over to you, sir.
Thank you so much, Rohan. And thank you once again, everyone at IRSI, at Youthful IRSI, for having me over. And it's really a pleasure to be a part of this wonderful program. So I've been given a topic which, frankly, I'm not very used to talking about. But it is something which is very close to my heart. And this is something which I'm doing day in and day out now. I mean, maybe 50% along with my clinical practice is going into spending the time on newer projects, newer hospitals, and newer expansions. So it is something definitely very close to my heart, and I will try to share some of the learnings, and also try to share some of the mistakes that we have done in different locations and different places, and what has worked and what has not worked to the extent possible. So the brief which Rohan gave me for this topic, when he said brick and mortar, I also thought it was going to be more about the team building aspect of it. But he said, no, we actually mean the real brick and mortar. We want you to talk about the building. How do you go about the designing, the internal layouts? What do you have in the building, and how do you go about planning when you start a hospital? So I would like to submit that these scenarios are extremely different depending on where you're practicing, whether you're in a tier 1, tier 2, or tier 3 city. A lot of what I would say would be totally not applicable for, let's say, someone in Bombay or maybe even in Delhi, where the real estate is at such a high premium. So you have to be very smart, and you have to try and put in everything into a much smaller area. We in South India probably don't have that problem as much, and are able to have much larger practices, and space is less of a constraint. The second aspect would be existing places where you're already located versus opening in a new territory. That would also be important in how you plan your location, and how you design your building. It would also be very, very important based on whether you're a solo practitioner versus a group practice where multiple doctors bring in their patients, or you're an institution or a hospital. And really, one size does not fit all. And we also have hospitals which is a tertiary care, which is a 6-7 story building, but we also have practices which are just a ground +1 or ground +2. So a different thought process goes into planning each of these things, and I will try to share as much as possible over the next few slides. Now, before we even decide on what to do with the building, first we have to look at what would be the location. And location is very important, especially if you're in a new territory or starting out a new practice. Whereas it is possibly less important if you already have an existing presence, and you're just trying to move into a slightly a better premises or a larger premises because your practice has grown. Because in that situation, it is possible that patients will still come in search of you, even if you're not located exactly on the main road and you're probably a wee bit inside. While the reason is the prominent location gives you only an initial thrust, and after that it's entirely word of mouth. You could be in an excellent location but not have the right people inside, and it really won't matter even if you have the best location in the city. So it's really important what type of team and doctors that you have inside. And if you're already in a place where you're existing already and expanding, I would say don't spend too much on location, because obviously it comes at a premium and you have to balance the cost when you're looking at expansion. So I'll try to explain this with a couple of examples. The one on the left is our hospital in Tirupur, where we already had a presence, and we were there for more than a decade before we thought we needed a larger hospital and a larger practice. Now, this is definitely not in a prominent location, and this is located almost under a bridge, but it has served the purpose because we were already there at this location for a long time, and the patients were able to locate us quite easily and came in search of us. Whereas the building on the right is our hospital in Cochin, where when we entered, we were completely new players in that market. And this building is located right next to the metro station, right in front of the bus stop, and on a very, very prominent road in Kochi. Now, this was important because it did help us get that initial thrust, give us that initial visibility when we were completely new to that town. But having said that, 4 to 5 years down the line, Do I feel that this location is still playing a major role in our presence there? Not really. So I think it is just in the initial year or two where location makes a huge difference, but becomes less important as we go out. A third example is a mid-sized branch, let's say located in our E-Road place, where this is actually located a little away from the city. Again, this is something which is located about 100, 150 kilometers away from our base center in a tier 3 city, where traveling within the city is really not that difficult. So even though we were located a little outside, it took us very little time to gain the prominence, and it became a successful branch in a much shorter time than even our branch at Kochi, primarily because you are expanding into a territory which is within your own backyard. So all these things go into your decision making when you're looking at a location. Now, do you try to buy the property, make the building, or do you go for a rental? Now, this is a very, very pertinent problem that many of us face when we are trying to start out and start our initial practice, or if we are already having a practice and you're wanting to start another branch. So obviously an own building or the land that you own requires a very high amount of capital. Your property itself gets locked because obviously you're not really planning on selling the hospital. You're making the hospital for you to work in it, for your colleagues to work in it. So the property itself, if it were left alone somewhere else, it would probably appreciate and you might be able to sell the property at some other date, whereas you may not be able to do so here. Yes, there is an initial rental cost which does come in, but then there is a lot more flexibility when you go in for a rental building, because you could even decide at a future date, 5 years, 10 years down the line, that now I need a bigger presence, better presence, and you would go in for a different location. All this becomes exceedingly difficult when it is your own building and your own land. It becomes quite challenging. And also, I would say we need to balance the expenditure between equipment versus establishment. Now, if you've spent a lot of your budget on establishing the building and establishing the presence there, it would be difficult for you to spend a lot on your equipment. But ophthalmology today has become an extremely investment intensive branch. And if you have to invest in various subspecialties, cataract, retina, refractive surgery, cornea, glaucoma, all of these, right from investigations to equipment to LASIK machines, everything comes at a very high cost. So I would say if you are able to reduce costs on establishment, that is, you reduce your capital on the property, reduce the capital on the building, you would be able to invest more and spend more on the equipment. And this definitely seems to be the way forward. Now, when you start with the building itself, once you have located the location, now you want to get the team together to start the building. Now, there are ways in which you can do it. Like if you are personally going to be involved in monitoring it, you could either go in for a single contractor who's going to take it as a turnkey project, or you could have multiple subcontractors, somebody who will do the civil part, somebody who will do the portion of the interior, somebody who does the electrical, somebody who does the plumbing, and overall somebody else who does the air conditioning and other things. Now, you might be able to save some amount if you have multiple subcontractors and you bargain with them and you coordinate with them. But this does require a lot of your time and a lot of your presence to ensure that this coordination happens between multiple subcontractors. A single contractor would be useful if it is in a different location from where you're primarily practicing, or if you are required to complete everything in a much shorter timeline. Let's say in a rental building, you have a very short rent-free period, maybe 3 months or so, when you need to complete the entire project and then start working from the 4th month onwards. There, the single contractor, you can push them because they will be responsible for completing the project on time. There will be penalties if there are delays, and they can be pushed to ensure that they take care of the coordination and finish the time, although it may come at a slightly higher premium, but it may be worth it because you will save on overall time. Next is about once you've decided on the contractor and your location, based on the type of footprint that you have, the kind of square feet that is present, you need to decide what are the number of consultation rooms that you require, what are the number of optometrists that you're going to put in place, the kind of investigations that you're going to have, and also the number of operating theaters, based on which you will also, depending on the remaining space, you will decide what would be the amount of inpatient and ward area that you have, and then the waiting area and opticals, which is then comes hand in hand with the rest of what you have decided. So just to go through this and add a couple of points on each of these areas, I have chosen an example of a small to mid-size branch located, let's say, on a ground +2 level. And this is a kind of a typical floor plan that we have. If you can see on the right is usually the kind of the common areas, the lift, the staircase, the common toilets, all go towards one side, and it doesn't interfere with the rest of the floor plate. So that is, this will be the recurring theme across all floors, the ground, first and second. And then in a very, very prominent location, which is along the front facade of the building, you will have your opticals, which is visible from the main road, because that is one of the areas where you do a lot of branding, a lot of visibility it gives in, compared to all the other rooms where we actually require a lot more peace and quiet, and the area has to be a little dark. Obviously, facing the entrance would be the reception itself. The pharmacy is also preferable if it is in the ground floor. We have most of the prominent consultants usually along the ground floor, along with some refraction cubicles. And along with the prominent consultants, you give them a counseling and a mediclaim unit as well, because all these patients who do get seen by the consultants go in for counseling. Subsequently, in the floors above come the majority of the investigations, your lab workups, your various investigations. I'll go through it in a little bit more detail, but that comes in the first floor, along with some consulting and waiting. Depending on that number of floors that you have, you may have some amount of a ward or inpatient area overlapping into the investigation floor, or they may be in a separate floor altogether. Basically, the idea is that you have your majority of your clinical in the ground and first or the lower floors, and then you have the ward above it. And on the top floor, you have the final inpatient rooms and the operating theater complex. The advantage of having the operating theater complex in the top floor is because your air handling units, which are usually located on the terrace, have direct access to the operating theater, and therefore it becomes easier to keep this in the top floor. The amount of distance, if you reduce the distance from your air handling units to the operating theater, you reduce on cost, you reduce on efficiency of you improve the efficiency of the air handling units. Whereas greater the distance, longer the amount of copper required, longer the tubing, longer the dissipation of the air conditioning, and therefore less effective air conditioning, or you require a greater efficiency of the air handling unit to operate a similar sized theater, which is located a little further away. So these are certain very broad outlines which go into designing and planning your things. Now, let me get down into specifics. Now, let us say this is in a smaller branch, a particular reception, and I will say this is on the opening day of a hospital where this was a good few years back, where we were not possibly as organized as we are today. And as you can see here, while this is a decent reception, there is absolutely no branding visible on the opening day in the reception itself. All of this came later. So nowadays, in this day and age, it's important that you have adequate branding across all the walls. As you can see here, this is all on the opening day, and everything looks absolutely empty. Now, whereas even when you are in the planning stages itself, your architect himself can start giving out the layouts for where your doctor board should go, layout for where the services should go, your different branding for different services, different creatives, where all these should be located. Based on that, he will decide on where the individual rooms and individual investigations and individual consulting rooms are all located, and the branding can also be used in those specific areas. But one thing I would like to add from this picture is to have a uniform theme, so that in all areas across the hospital, this theme is kind of maintained. And this theme should ideally be, if you're having more than one branch, it's good to have maintained the same theme across different branches as well. You would also notice that in all the rooms, we have laminations put up to a height of about 7 to 8 feet. And beyond that is the ceiling. So because the reason is this becomes very maintenance friendly. Even if patients keep their hand over the wall or other things, it doesn't get dirty. It can be cleaned very, very easily. While there might be a slightly higher initial cost when you're putting laminates instead of just a simple painting, but it does help in the maintenance in the long run. And I think this is what most places are moving over to now. Even in the waiting area, depending on the type of branch and size of branch and amount of waiting area, you can have row seating, you can have lounge seating, you can have separate general areas, you could have a smaller VIP area where your either your express patients or possibly premium patients or pre-refractive surgery patients could have a slightly different waiting area setup. And this is something which we do follow in a number of locations. In the consulting rooms itself, again, you would see that the theme, which is there exterior, is also maintained inside. You would also want to design the consulting room in such a way that it has sufficient space for your chair unit, but also gives the consultant a kind of like an office space, that is a desk with a chair and a couple of 2 or 3 chairs in front of it for the patient and attenders to sit. Now, a lot of places would have a small computer right next to the chair unit and save up on space. Now, that's also a good idea. If your space is a constraint, you could just have a room which is possibly half the size of this and having more rooms for consultation. But if you have space, it's good to just do the examination here and have a separate kind of space where you actually discuss with the patient and the attenders in front of the table. And this is something which we religiously follow. And it's a typical layout and floor plan that we use. And it's also important that these tables are made in the layout itself. When you're making the consulting room itself, where the table is going to be located, where the drawers are going to be located, where the wash basin is, where the chair unit is. Because all the electrical lines, the spacing, everything goes according to this. Your internet lines, your Wi-Fi lines will be located close to where the computer is going to be, whereas your chair unit, where all the electrical lines for your chair unit, indirect, everything goes on the other side. Whether you need a right-handed chair unit or a left-handed chair unit will also depend on the orientation of the chair unit. So all these things, it's good to have them in the drawing rather than just label it as a consulting room and completing it, but go into the specifics, ask your architect to make all these layouts so that every other planning of your internet, electricals, everything goes accordingly. Your optometry lanes should also be standardized, and these can be standardized cubicles where you could have a pre-optometry space or a pre-refraction space, as we call it. The pre-refraction space has again electrical lines along the flooring with a small hatch kind of thing which you can open up when you want to connect the plug points or switch on something. The NCT, the auto refs, the slit lamp all goes into this common area. And these refraction cubicles are usually a standard 3-meter length. You could have a 3-meter chart, or you could have, if you have a mirror in the opposite, you could have a kind of 6-meter chart with a 3-meter distance. And this is an error which you can see here. Now, that's one of the reasons I pasted this particular picture. Now, all of this optometrist is sitting here and the patient is on to their left. But if you'd see, most of our optometrists would be comfortable using their streak retinoscopy on the right hand, being right-handers, and this should ideally be reversed, and the door location should also be on the opposite side, as the mirror or the electronic chart should be located directly opposite to the patient. So this should be reversed, and this was something which was noticed during the planning stages itself, and this was changed. So it's important you get all these layouts done when you're in that initial planning stage itself and not wait till you complete the building and then identify these errors. Investigation rooms also can be planned in a similar way. when you decide on what are the investigations that you're going to have, topography, your retina lasers, your OCT, B-scan, glaucoma investigations. Based on that, you can start earmarking the rooms and again make the layout. So if you're having a laser, the kind of whether they are using a LIO or a slit lamp laser delivery system, whether they are using a ECG in the lab, or whether they're using an immersion, which may require the patient to be in a reclining position or in a bed. Again, for topography, you might require lesser space. For fields or an OCT might require a slightly larger space. Based on that, you can have the internal layouts and the investigation made, the plug points, electricals, everything can be decided accordingly. Earmark all of these, what is going to go into each investigation room. While you may not be able to plan everything, and there might be some customization which you may need to do as you go along, and you may not invest in all the investigations in the beginning itself, but it's good to earmark what potentially could come into each of these places, even if you're not buying them in the very beginning. I won't go into the great depth of the interiors of the operating theater, because that's, I think, a separate topic on how they are going to plan the operating theater complex. But suffice to say, having HEPA filters over the table, and your laminar flow, and you could have a modular OT if you're comfortable with it. While many places do have a single table concept, we have a dual table concept in all our centers and follow the double table system. Based on that, your size and space inside the theater for trolleys and the phaco machines to move on either side, all that has to be planned. So a minimum theater size that we go in for is usually a 16 into 16. And like I mentioned earlier, it would usually be in the top floor. And also we plan in such a way that the sterile and unsterile corridors are completely separated. So you have a unilateral flow. So the patients, after changing, they go into this sterile area. Then the equipment goes into the operating theater complex. Then when you see, once the unsterile equipment go into the autoclave room, from the autoclave, they go into the clean equipment space, and there are pass boxes on either side through which the clean equipments go into the operating theater. So because of this, we will have a unilateral flow of the equipment, and this is important as per NABH standards. Also, another important thing which I missed out is also you should plan where each location should have the fire escape, and that fire staircase should also be marked in the beginning itself, so that again, this is an important part in your approvals, and your fire staircase obviously can't be a part of your theater complex. So where you're locating your theater and other things goes based on the location of the fire staircase. So the optical service is again something which is now become just one. Yeah. So the optical services is part of an integral part of our hospitals. So we have an optical outlet in all the branches. But then again, you should also remember that these optical outlets within the hospitals are now competing with very fancy optical outlets in almost every city, with the regular lens cards, so many other branches of various opticals which are there across all cities. So it's important that they get a nice, wholesome experience even in your hospital, have less counters, have more areas where the patients can experience, get the touch and feel, where they are able to go select the frames, pick up the frames, try it on themselves, have more personalized counters, smaller counters, and this kind of helps in your optical outlet as well. When it comes to the ward and daycare unit, you can have different spaces based on the kind of size that you have available for making your daycare units and your inpatient rooms. Obviously, most of us have shifted entirely to daycare surgeries, whether even retina and cornea surgeries nowadays, we discharge the patient on the same day. Very few of them are admitted. So you could have a daycare like a lounge where you could just have curtains separating them, a seated sofa, recliner. The patient can just lean back because they are hardly there in the hospital for a couple of hours, and that's quite sufficient and is very requires very less space. You could have some rooms also where some patients could stay overnight with attached toilets. These are, again, like I said, maybe for your few retina and cornea surgeries, which our patients are staying. Apart from the daycare, we also have a slightly more different modified daycare unit, wherein some of these may not be just recliners, but a small bed with an attached, just a small chair for the attendant to be in. Again, these are meant only for daycare surgeries, but allows the patient to rest even if they require a specific positioning to be done after retina surgeries. It can be done even in a daycare room as per the comfort of the patient. You can tailor make it as per the space that you have. If you're planning on doing camp surgeries like we do in a lot of places, it's important to have a general ward as well. You could use it also as a slightly step down daycare for the lower packages, where patients just lie down, get the surgery done and leave. Even camp surgeries in many places are being done as a daycare, where the patients come early in the morning, get investigation done, get operated and leave in the evening. What you don't see in the infrastructure, but is the most integral part of any hospital, the backbone, is the EMR and the hospital management software. And while there are multiple options available today, I think it's important to invest in an EMR and ensure that there is uniformity, that you have easier reporting, easier cross consultations, and so many other records that uses that can be, and it could be a separate topic in itself. You would also possibly do well to bring into your budget investing in a camp vehicle, because this is, again, with something which is very useful, especially when you're starting out, to do some camps, to get the word out that you're a good surgeon, and word of mouth can build up very quickly through camps as well. If you have a slightly larger space, or you're a teaching institution and you're planning to be a teaching institution, it's important to have boardrooms, have libraries, and have an auditorium as well, if it is possible. I'm not saying we have this in all our branches, but in some of our places where we have fellowships and DNB programs, we do have these facilities as well. And this could also be something which could be in the back of your mind. So constancy in interior design, having a theme is important. Maintain uniformity, having maintenance-friendly interiors, like having laminations and glass. This thing, though it might be initial cost might be high, but the long-term benefit of lower maintenance and easier maintenance is definitely something which we can easily practice. Thank you so much. I hope I have conveyed a small portion of what might be interesting, and I look forward to any questions and comments.
Sir, this was an amazing insight into everything. I mean, you literally mentioned each and everything that could possibly occur in anyone's mind and run through it so smoothly. So thank you so much for sharing so much insight.
Thank you.
Absolute justice. I don't think anybody could have done more justice. It's because you're doing this, sir. Especially the layouts, the details, the thought process, the retinoscopy, right-handed person, the mirror, the placement of the door, all those things. I mean, people just don't think about it in general, but these are such important things to have to do right in the beginning itself. And as you said, branding, it's become such a huge aspect. So when you're planning the infrastructure part, you should plan it in a way that you can do your branding accordingly. I absolutely agree with that. Dr. Mehta sir, your comments?
I think most important, being very frank in showing off everything. He's not kept any secrets behind. Couldn't be a better example of sharing. This is something very nice, pictorial representation with a flow chart and the floor plan. Nobody shares their floor plans. Keeping the toilets on one corner, the AHU, which is so very important, where the air is being drawn from. Otherwise, you will get some dirty smell if you have a nearby factory or something else. And getting a fresh air into the OT, it's a big deal if you don't have a proper air handling unit, air conditioning and your sterility. I think brilliantly placed, the whole thing. Very well done. Optical showroom, he did not mention much about the chemist as yet, but I think these two would be the, three places where maximum, if you go to any big hospital like Leelavati or Nanavati, as I say, three places where you would meet people. One is the chemist shop, optical, of course, incidentally, canteen, and the loo. These are the three places where you will meet everybody. whichever department they go to, these are places which they'll have to use. So these are very well said, very well done. Thanks for sharing.
Thank you, Dr.
Okay. We introduce our next speaker. Do you have any questions, Ron?
Yeah, no, I just wanted to ask Dr. Saurabh also, because he's got a an institute in Noida, where of course it's old. So adding new places to it, sir. So how has it become different in the last decade or 2 decades when you are adding new places, new infrastructure to your facility?
It's always a challenge. It's always a challenge once you're refurbishing something or you're replanning it, and it's a process of breaking down a lot of things, bringing down walls, and the standards also have changed over a period of time. So once we started off, there were no standards to follow. And soon there are other standards, the NABH standards, as well as you need accreditation from various authorities to be able to function. Your firefighting equipment, your passages around that, your NOCs from various statutory compliances, they come into account, and it is very, very difficult to change a place. And that's what we're in the process of. We've changed quite a bit in the hospital because it came up bit in pieces, a few rooms at a time, and then a floor at a time. And then the OT was on the ground floor, which was shifted onto the first, then onto the second, and now onto the third. So we've seen that transition. So we've seen that it was a one-room OT in the ground floor, and now we've got the full floor on the top. So it is a challenge, and I learned quite a bit from Shreyas today, because I've been to a lot of hospitals in my initial journey when I was I used to assess I was assessor for NABH. So I think he did justice to his topic, and
Thank you, Dr. Senthil, sir. Your comments. You've been leading 2,500 ophthalmologist group, and you get a lot of queries from people regarding this.
Yeah, one question to Dr. Shreyas is, when you start this center in a town like Erode, which is already, the city of Erode already has a lot of eye hospitals. So how much time does it take for the center to break even in a smaller town like Erode?
Do you want the honest answer, sir, or yeah? No, let me be. Let me.
I
be
think
very,
you have
very
been honest with your presentation.
Yeah. No. Let me be very, very honest, and I think we have also been very, very lucky that generally we break even in the third month, sir.
Okay.
So that is operational break even, not the investment break even. Investment break even possibly is usually between 2.5 to 3 years.
Okay. So the challenge, I think, is to, in terms of opening new centers, is in getting doctors. I think that is the biggest challenge you might be facing.
Huge challenge, sir. Huge challenge, definitely. And getting quality doctors and getting doctors who can maintain the same standards that you have across all centers. So it is a challenge, but I think overall, with a robust training program and with the fellowship program and other things, that has also helped us along the way.
Sir, how do you manage to go around with each center? So do you physically go there every week or every month or something, and how do you supervise it?
We have a schedule for physical visits as well, but the physical visit for each branch is possibly once in 2 months or once in 3 months, because right now we have 16th, 17th coming up. But then so it's difficult to visit every place physically, but we have a virtual standardized slide deck meeting, kind of like a review meeting of each center every month on a specified day. So that's where most of the discussions happen. Of course, there are ad hoc discussion, problem solving, troubleshooting, which happens even otherwise, but overall performance guiding, everything happens through review meetings, which is usually online.
So I think Zoom has helped. Zoom has really helped.
No, I would say COVID has helped because it made it difficult. For a long time, our branches in Kerala and other things, I could not even cross the border without having to stay on either side for 5 days of quarantine and all that nonsense. So really, it taught us that you could stay in a space meet virtually and still have good discussions. But yes, it does not, I'm not saying it totally replaces going to the center, because you need to have that connect. So, and you need to have a certain ground level connect. But I think even larger organizations than us have totally stepped away from any physical visits altogether.
Thank you. Thank you so much, sir.
In fact, one of the NABH assessments, a few of the NABH assessments during that time were on Zoom meetings.
Yes.
So, sir.
It's my pleasure to introduce our next speaker, Dr. Saurabh Chaudhary, the Chief Executive Officer and Medical Director of Eye Care Eye Hospital. Dr. Chaudhary is a leading refractive surgeon and has been active in imparting surgical program where hundreds of ophthalmologists have trained under him. Also an ex-NABH assessor, we welcome Dr. Saurabh on the show, where he will talk to us on the nuances of setting up an OT.
Thank you, Pooja. Thank you for the invite. Thank you, Rohan. And it's always good to be associated with the IRSI and especially the Youthful wing now. And this is my first visit to this forum. And I must say it is really impressive to think that the youngsters are also thinking about how practice should progress further and how things should span out for them. So taking it forward, the building blocks of ophthalmology, that's what we are saying, that it is very important that we as youngsters who come out from our medical colleges, we finished our BNBs, we finished our MSs, and then the fellowships, and then we now have to set up a practice, and that's the right forum where we should all think about various ways. And it was great to see Shreyas present his talk. I'll be more importantly talking about the operation theater and how you should go and set it up. Being an ex-NABH assessor, I have a lot of experience in going to various hospitals, seeing them, looking into the qualities. So I have actually played around a little bit on the NABH scene, because every setup, any ophthalmologist setting up a new setup should look into it, because ultimately that's the way forward to keep the quality under control and to be able to give better care to the patients. So cataract surgery has become one of the most commonest surgeries around, and basically a lot of cataract patients are landing up in various hospitals, especially the major ones, and there is a backlog of these cataracts, as we know, and we've read about it. But as more and more patients are landing up, and there was this COVID time when there were hardly any patients, and with the boom, a lot of patients coming up, there has to be standards of patient care so that we are not in a mode of like a fish market where we're trying to take care of these patients. And the infrastructure, especially of the OT, is the backbone of any practice. And Shreyas has talked about the infrastructure of the hospital. I will be just including the operation theater. Just a slide to introduce why is it called an operation theater, and most of us would have seen this slide, that it was a theater where the students sat in the galleries and the surgeons performed in the center, showing, and there's a blackboard at the back where they could actually write. So everything was being done. And slowly over a period of time, we learned our ways of sterility. We understood how we could give better care to the patients. We understood how to, so we moved on from this to better infrastructures, to first to formalin, then aldehyde, then moved away from aldehydes, from fumigations, and now onto the HEPA filters, as Shreyas was talking. So we have moved on to better theaters, seamless, modular, and we are in an era where most of the places have good setups like these. But what is an operation theater? So it's a complex environment. When I say complex environment, I don't mean a complex as an infrastructure, but an environment of varying degree of sterility. And what does that mean? And I'll explain that in the future slides, which is integrating surgical and anesthetic techniques for a safe conduct of a surgery. So the operation theater is an infrastructural complex as well as an environment where what we're talking about. There is no standard design of an operation theater. So it's not that I will say, okay, this is right or that is wrong, but we must conform to the basic parameters to maintain a sterile OT environment for the safe conduct of a surgery to give better results to the patient. Whenever we're setting up an operation theater, we just need to know that there are some zones based on sterility, and we need to be talking about them in detail. And I'll do that in the future slides. So this is just a slide to show that there are different zones, the unsterile zone, the semi-sterile, and the sterile zone. And these are all are sacrosanct in their own ways, and we should be trying to maintain these zones as they are, so that our patients do not land up with complications like endophthalmitis and other surgical site infections. So the first zone, I'll say the zero zone, is the outside the operation theater, where the patient's relatives are waiting, the patients come in, and as Shreyas was showing the wards, the daycare facilities, the lounges, and there should always be a mechanism from how they are going to move from one place to another. The first zone of the OT, that is from zero zone to the first zone, is the entrance area for the patients, the staff, and the supplies, where the normal hospital standards of cleanliness apply, but you can wear your everyday clothes in it. So as a surgeon, as you enter in with your clothes, and then you've naturally taken off your footwear before you're going in. And as you go in, you enter the second zone, which is the clean zone. So to pass between one protective zone to the clean zone, everything must undergo a system of transfers. The system of transfer means that if you're a surgeon, you need to change out of your street clothes, get into your scrubs. All patient staff and supplies must be clean. Everybody must go a complete changing routine. So the patient should undergo a donning of the gowns, or they need to change their clothes before they get into the OT. So all those systems must be followed. So then there is the aseptic zone, which is the inner zone where conditions are as near sterile as possible. You can never say that there is a infrastructure where it is totally sterile, but as near sterile as possible. And all staff who might be handling exposed instruments must be scrubbed and gowned. So you scrub, you gown, and then handle the instruments as well as the patients. Then comes the most important zone, which is a disposable zone, and all exposed instruments, used or unused, specimens, suction jars, soiled linen, are passed from the theater to a disposable corridor, and which are returned from a cleaning, sterilizing to a CSSD or to the other necessary processes. I will be talking about that in the future slides in the theater layout as we talk. So the operation theaters are scientifically planned. There has to be a barrier system. As I said, that if you're going from a zone to the other, you need to get out of your street clothes, get into your scrubs, and then once you into the main area, and if you're operating, you need to get into your gowns, the sterile gowns, and operate there. So when we are talking about the operation theater complex, as Shreyas said, it should be located away from the inpatient area. It should be located away from where the main action of the hospital is taking place, and it can be on the top floor. And as Shreyas rightly pointed out, things become a lot easier once they're on the top floor. The walls should have minimum joints. I will be talking about the walls, flooring, and the false ceiling in some of the other slides there. But before I go forward, as I said, the walls should be of an imporous material with minimal joints, and you can actually have large sized tiles on your OT walls. You need not have a modular OT, and that's what the NAB standards show. But once you go on and once you tell a turnkey contractor to build a OT for you, he will definitely make a modular OT because he's making money out of you. So you can actually, to save money, can have the walls which have minimal joints, the floorings, which could be any material which is non-porous, but the junctions between the walls and the flooring should have a coving. That means it should be curved around so that they can be cleaned very well. The false ceiling could be as simple as a gypsum, but you have to just think like a common sense that no surface where dust can accumulate. So you make sure there are no surfaces. The lights are all covered with the clean room ISO standards, and we'll talk about it as we go on. But the UK Medical Research Council has given the 6 basic design requirements, and we should always keep them into mind. The first is that separation of the general traffic and separation of the air movement of the hospital, and we'll talk about it as we go on. the sequence of increasingly clean zones, and that we did talk about the 4 zones that I talked about, from the entrance to the operation theater and the sterilizing areas. There's an easy movement of staff from one clean area to the other without passing through the dirty areas. And there should be a unidirectional movement without crisscross. And we'll also talk about it when I'll show you the scheme of the OT layouts. The removal of dirty materials from the suit without passing through clean areas, airflow from clean to less clean areas, heating and ventilation, and we'll be talking about each of these points as we go forward. So here, as I said, there should be no crossover of sterile and unsterile equipment and personnel. Wherever possible, there should be barriers like airlocks, like sluice. That means that there are a couple of doors. So one door opens and the other is not open. You go through one door and then go into the other. So these are some barriers which you can all easily create. And then there should be easy accessibility to the CSD through the dirty corridors. And I'll just try to show. This I've just penned down on my own last night, trying to put down a schematic layout of the ophthalmic OT. And where I've written that this is an operation room, I won't say it should be operation room, it should be operation theater here. I have tried to divide it vertically down here in the center, keeping this as an unsterile zone, keeping this as a sterile zone. So I'll just try to explain why. So unsterile zone, the patient is coming from outside into an outpatient out corridor here, which is the outside corridor where he is made to wear his gown, made to change out of his clothes. Then he goes into the semi-sterile zone as the anesthesia room, from which he goes into the operation theater. From the operation theater, he goes back into the recovery area and then outside the outside corridor and back to the wards. So it's a unidirectional flow, which is a circle which the patient is following here, coming into the yellow sacrosanct zone, which is the totally sterile zone. Similarly, staff coming in from a different entrance comes into the operation theater, gets into the changing rooms, from where goes into the scrub, operates, dons the gloves as well as the gowns, operates here, disposes them, and then gets into the staff room. Again, the staff movement is in a unidirectional area movement, and it shouldn't. But as we're already in our scrubs, surgeons can move around a little bit, and the OT staff can move around. Now, this is very important, which I call up as a lay up area, and it's coming directly here. It's the most important bit here. So let us suppose there is the central sterilization department from which all the sterilized equipment is being shifted into a sterile storage. From the sterile storage, it goes through the layup area, through a pass window or through a door into the operation theater. After the surgery is performed, it goes out through a separate exit. So this is the entry through which the sterile equipment has come in. The procedure has been performed. It is going out through a separate pass window or a door back into the lay area, which is a part of the unsterile zone. So it comes here, and there is a barricade in between. So it comes here, it goes into the dirty utility, from where it goes into the cleaning and packing. From the dirty utility, things which have to be disposed go out. And it is not the same area where the patients and everything have gone out. So it's a separate circle. So this circle is the most important bit, that there is no crisscrossing. So there are no dirty equipment, there are no dirty instruments which are coming back into this sterile layup area, into the sterile storage. So it's only a unidirectional flow. And it is not that the sterile equipment is going through the same window as where the dirty equipment is coming out from. So it has to be a separate area, and these should form the basis of your operation theater design. If you keep these in mind, you can design it anywhere along it, wherever you want your operation theaters, wherever you want it. And I did try to show up a schematic architecture here. So that's where the patients are coming in from. This is the pre-operation operative holding areas. The doctors are going in from a separate entry into the change room, the male and female. They get into the clean corridors here from here. They can go into the operation theater, come out, come back into the change room. So the doctor's movement is basically here, and then they change back and go out. The patients go into the pre-operative holding. From here, they're moving into the clean corridor, into the operation theater. Now, when they're going here, there is no dirty equipment, nothing passing through here. So they're going in here, getting operated, coming out, back into the post-operative area, can have a different exit, but they can also come back out through the same exit. this is the most important bit, that these are the operation theaters where the sterile equipment has come in from. And I said that this is the CSSD, this is the storage, a flash autoclave here. It comes into the operation theater. Once the operation is performed, it goes out into this dirty corridor and back to the CSSD. So when we're talking about the dirty corridor, it is joining all the OTs on the outside, where each OT is shifting on its dirty equipment, everything what needs to be disposed out from this, so that there is a unidirectional flow, sterile equipment coming in here, sterile disposables coming in here, getting out from here, disposed here, which everything was sterile, all the equipment going through this dirty corridor into the CSD and back to the storage. So in one way, there is only a unidirectional flow which is coming here, back in here, back, and so there is no crisscross. The patients or the doctors are only crossing the area where the clean equipment, the clean disposables are coming in from, and not what are the reused, as well as the patients going in from here. So nothing, no crisscross between the disposed equipment and the dirty instruments which are going out. Similarly, this slide is showing those three simple sort of circles. So scrub, staff change, the scrub, and the operation theater, and back here. The disposal, the start off with the sterile preparations, the sterile storage, coming here to the operation theater, being used, coming into the disposal going out, as well as the instruments going back into the sterilizing department. Once it is sterilized, it is cleaned, it will come back into the storage, sterile storage, and then get into the operation theater. The patient in and out. So here we see that there is no crisscross between all these, and these are the basic principles of designing an operation theater. A bit about the CSSD. Again, as I said, it's just common sense, and if you know the schema, what I've told in the past 3 slides, you should just use your common sense and plan anything beyond it, around it, so that there is no crisscross. Similarly, there are 3 zones in your CSSD, where the soil, which is called the soil zone, and where all the equipment is coming in with a barrier, which is going into the clean zone. As the equipment gets cleaned, it comes here, and then it goes into a sterile zone, which goes into the sterile storage. So basically 4 main zones: a soil zone, a clean zone, a sterile zone where the sterilization actually is happening, and back into a sterile storage, from where it will be pushed into the clean corridor and into the operation theaters. Now, if you notice, there is a minus sign here, there's a plus and a plus sign here. This is basically trying to show that this area should have a negative pressure, so that whenever the door opens, or this barrier opens for a short while, the air from the clean area or from any other area should be pulled into the soil zone, and not the other way around. So whatever the instruments is here, the air is pulled in and is taken out to the air handling unit from here, and it should have a negative pressure here. So whenever the door is open, the air should be pulled in and nothing should be going out. Now, this clean zone has a positive area. So whenever this barrier opens, the air should be pushed towards the soiled area and not vice versa. Similarly, if the room is getting opened here, the air should go out and not come in. And there is a barrier here. So this has a slightly more positive pressure. It is coming in here, but this also has a positive pressure. When the barrier is closed, the air is being pushed out of the sterile zone. And the storage also should have a positive pressure, where no air is moving into it, but going out of it. And I will talk later what your AHUs and how the positive pressures are maintained. This is the OT design, and I've just taken some NABH guidelines from the 2010 and the NHS state guidelines, which definitely were very instrumental in getting the NABH OT guidelines. Now, the recommended dimensions are 20 into 20 into 10 feet, and 10 feet is height below the false ceiling. So there is a false ceiling which is mandatory in all OTs now, and this should be the area, and if you're planning an OT, this should be it. Keeping into account that if you're going in for a modular OT, the 20 feet will become lesser, but these dimensions are of the room dimensions, and if it becomes lesser, it does not matter. Now, OT in a single specialty hospital like ophthalmology could be a 300 or a 400 square foot area, but in a multi-specialty hospital, approximately 400 to 600. And The NHS recommends a minimum of 550, but in our scenario, with as Shreyas was saying, the space is very important, and we can actually manage in a 300 square foot area. Now, according to the guidelines, the OT construction is a normal room. The walls, as I said, could be just seamless, painted upon with antibacterial or antifungal paint. It could just be tiles, which should be cleaned once a week from top to bottom. There could be, areas. Is my voice?
Yes, sir, we can hear you.
Okay, so the OT doors could be automatic, and once, as I said, if you go to somebody who will design an OT for you, just because of standards being maintained, they'll push on an automatic touch-free system to you, but a mechanical would do perfectly well as well. And as I said, the walls could just be tiles which are cleaned every day. The general lights, you just have to keep the clean room lights ISO standards in mind. That means the light should be flat, recessed into the false ceiling, and there is no space where the dust should cover. The important part is that there should be safety against static charge. So the floor should be of vinyl or material of epoxy material with earthing, if provided, would help quite a bit. Now, according to the NABH standard, there's a super specialty OT and there are general OTs, and luckily ophthalmology comes into the general OT category. Now, when I am talking about the NABH standards, I'm not talking about the entry-level standards, because I am talking about the full standards. Because if you are making a operation theater or a hospital of your own, you should be looking at getting the NABH full level standards. You start off with the entry-level standard, that's for the first 3 years, and after that, you cannot renew the entry level and you have to move on to the full standards. And if you have not kept these things in your mind, you will never be able to move on, because as I said, it will be a case like us, breaking things, breaking walls, and the expenditure is a lot more in trying to rebuild something rather than designing something in the first go. What we also need to understand, and that was a big confusion here, that daycare centers also fall under the category of a general OT. So you have to have the general OT standards even if you're making a daycare center, and it is no different from a general OT. Now, I just put up this slide, and I will take it further on this slide as it comes. But the NABH, the standard is that there should be some particular number of air changes per hour. And in an ophthalmology OR, it is 20 air changes per hour. The air velocity should be coming, that means the force with which the air should be coming in should be 90 to 100 cubic feet per minute. The OT, the OR, the room where the operation is happening, should always maintain a positive pressure of 15 pascals, so that once the room opens, the air should flow out and not inside. So there is a positive pressure area inside the operation theater. The air is being filtered, and the only difference is that it should be filtered from the HEPA filter, definitely, and it could be not be a HEPA filter in a general OT. But there is a big question mark to it, because if you have to keep the air changes, the air velocity, the positive pressure, then you definitely have to put the HEPA filters, and I'll talk about it a little further. There should be two filters, a pre and a micro weave filter in your AHUs. Temperature should be maintained between 21 to 25 and below 18 degrees centigrade, and a relative humidity of about 55, which is the ideal humidity, which has to be maintained. So when we look at the standards, when we read them, nowhere it says that there is a modular OT required. And as I said, a modular OT is a seamless OT made of stainless steel or maybe some other materials, but you do not require a modular OT for your ophthalmology OR. But you definitely need a plenum, a HEPA plenum with the AHU on the top, so that it is doing air exchanges, and I'll be talking about it, because you will not be able to maintain these standards, what I've just talked about, if you do not have a AHU and a HEPA plenum. Again, in the same, I have just picked and copied it from the NABH OT guidelines, which says window and split ACs should not be used in any type of OT, because they're pure recirculating units. and have convenient pockets for microbial growth which cannot be sealed. So this is very important, that there can't be any split air conditioners or window air conditioners. The ductable normal air conditioners are also not permitted because they are also recirculating. So you definitely have to have a AHU which is dedicated to each OR. The flooring, walls and ceiling should be non-porous, smooth, seamless, without corners. As I said, they should have a coving and should be easy cleanable. Hermetic ceiling doors is recommended. And when we are showing the hermetic ceiling doors, it is not necessary that they should be automatic. They could be on the hinge as well, but they should seal well so that no air is passing between the two once they close. Coming down to air conditioning, and what we need to understand, that the word air conditioning is not only the temperature modulation of the air, but it is also conditioning the air to the right humidity, to the right pressure, to the right cleanliness levels. And according to a lot of tests carried out world over, the vertical laminar flow ventilation is found to reduce the count of bacteria by a factor of 15,000. And that's why it is the gold standard to have a laminar flow ventilation. And as I said, once we say it's a gold standard, you cannot do without a HEPA plenum in your OT. So OT, as I said, the AHU is nothing but something which is handling the air. The AHU cools the air or heats it. The moisture, it dehumidifies it. The air is filtered. It removes the dust particles, bacteria and virus, and it can also remove some gases and odors. So again, what is a laminar airflow? It is nothing but a unidirectional, non-turbulent air flowing in parallel lines. So the laminar airflow is filtered into the operating area from a diffuser plenum, that is the HEPA filter which is fitted in there. The HEPA filter has a 99.99% efficacy with a filter of 0.3 microns. It is very necessary to maintain a particular air velocity in the room so that there is a positive pressure, and once you open up the room, the air should be flowing out through the doors and not coming in. So this is just a sort of a diagrammatic version that if you have a normal OT, the air goes around, circles all around, it might be going down to the floor, then coming back onto the environment, getting back onto the operation table. But in a laminar flow, as it is coming down with the pressure, it comes to the patient. So this is purified HEPA, coming through the HEPA filters and the other filters in the AHU, coming down into the operation theater, coming down to the operation table, moving down towards the floor, and being sucked back from these openings on the bottom of the OR, getting here and getting back into the AHU and coming back here. So the AHU has 5 filters, but you can make way with 3 also, because that's what the general OT standards are. The 10 micron pre-filter and the 5 micron fine filter are important, as well as the HEPA filter, but the UV and the other filters are optional. As I said, out of the 5, the first 4 are fitted into the AHU, and the HEPA filter is fitted into the plenum. The AHU is kept outside the OT. It is normally floor mounted, and you have to punch out a hole into the ceiling. That's the best way to go about it, so that the AHU is pushing in air from there and getting into the plenum of the HEPA filters. Now, fresh air is always being added, and as I said, there should be 20 changes per hour that should be happening in a general ophthalmological OT. What about the air conditioning? The air conditioning could be anything. It could be any unit, a VRV unit. It could be a central unit, which is just chilling the air and feeding it to the AHU. So what we need to understand, that AHU is totally separate, and the cooling or the heating of the air is a separate unit altogether. They can be married as it could be even a ducted unit. It could even be a tower, a water cooled tower, or an air cooled tower, which is giving in the chilled water copper wires down to the AHUs to cool the air. So there is a air conditioning unit. Each OT has to have a single AHU. So in case you have 4 OTs, there have to be 4 AHUs on the ceiling for each OT separately. These AHU, as I said, are basically pulling in fresh air, making sure that they're going in with the pressure, making so the fresh air, this is the inlet, it is coming in, going through the pre-filters, the other filters. This is where the dehumidification takes place. This is the cooling coil, and this could be from any refrigerant. It is coming here, going through the heating coil, which is dehumidifying it. And here it is pushing the air down. These are the two ducts where it is being pushed down. So this is what it looks like, with the air being pushed in, the air being dehumidified, pushed in with the pressure, and it can go out. And see, in case you look here, there's a punch in the roof, and it is going in from here into the plenum. So this is the plenum. So the air is being supplied from here into the plenum, which passes through the HEPA filters, which are here, out into the OT. It could look like this, where the air is coming in and the lights are integrated inside. So the air is coming in, the OT table is right below this. The air comes in here, it goes down, as I showed in the schematic drop, goes back into the AHU, and fresh air is being added all the time. Now, there are some issues with the ophthalmological setup in these, because let's say it's a very rainy day and there are 20 changes per hour. Fresh air is being added all the time. So you definitely have to have heaters in your AHU, so that the air which is being pulled in is not having too much of humidification, because all your oculars will start getting condensations on them. As I said, there should be a positive pressure system, and that's what is the role of the AHU, which is pushing in air so that everything coming into the OT is going through these filters. And whenever the hermetically sealed doors open, the air should be going out and not coming back in. And that's what the 15 pascals, what I said, should be. The air velocity, so that's again unidirectional, downward onto the OT table, and it is recommended with the national and the international guidelines that it should be of 90 to 120 cubic feet per minute at the grill or the diffuser level. And this you do need to check at most times. And I've told about the 15 Pascal of. The temperature should be maintained from 21 plus minus 3 centigrades with a corresponding relative humidity of 40 to 60, 55 being ideal. There should be appropriate devices to monitor and display these conditions inside the OT, so that you know that everything is going on well. Besides this, there should be validation. So I'll just go on to these slides. These are the walls, the hermetically sealed doors. These are the other things in the OT control panels. And this is what is telling you what the situation is. So these are on the walls, which is telling you the time of the day, the time elapsed. This is where you set your OT temperatures in, what the actual temperature is. It is showing here. This is the relative humidity which is being shown. You can set up the humidity which controls the heaters on your AHU. This is the pressure inside the OT. So the door is not closed fully. That's why it's showing 7. Once it is closed fully, it will show about 15, more than 15. And as the door opens, the air will flow outside the OT, and the pressure inside the OT will decrease. So this is again a schematic diagram of the same. You can actually have the control lighting, which is not present here, and as well as the telephone systems on here. But this is just a sort of a control board in your OT where you can control all the parameters from. So, and check that whatever you've set is being followed. So these were the most important things in an operation theater. Besides that, you also need to look into the scrub stations. As I said, it could be anything, but they need not be automatic. It could be anything. The pass boxes, the C arms and the mobile arms wherever required, clean room standards as per the ISO, the NABH and the ASHRAE standard should always be consulted in a design process. So I've taken the references from the NHS Purchasing and Supply Agency, the NHS Estates, the NABH, as well as the American Society, that's the ASHRAE, the Heating, Refrigeration and Air Conditioning Engineers, as well as the Indian Railways. Thank you. Thank you.
Thank you. Thank you so much, sir. Thank you so much. It was great, amazing detail that you went into. So that slide that you skipped about the temperature and the humidity, sir. So what is ideal temperature and humidity inside the OT?
So as I said, the ideal temperature would be 21 degrees centigrade plus minus 3 degrees centigrade. So that's the ideal temperature which should be set. So it could be between 18 to 24, 25, anywhere, right? The ideal humidity is between 40 to 60. The parameters should be between 40 to 60 relative humidity, but 55 is the ideal relative humidity, what should be set on your plenum. It will maintain, if you set it on 55, it will be varying between 40 to 60, because as the AHU will be working, it will be pulling in fresh air, and depending on the humidity levels outside the OT, as it is pushing in fresh air, it will go about changing the air, and fresh humid air will come in and it will increase. And as the heater kicks in, it will come down slowly.
So one quick question, these rules apply for refractive OT as well, or it's mainly for cataract OT?
So as a system, and especially in our hospital as well, we don't call our refractive OT as a refractive OT. We call it as a laser room. So it's a refractive laser room, because it is impossible to get these standards going in for everything, and especially in the refractive OT, where you do need the recirculating units, because you can't be pushing in humidity into a refractive unit, because the oculars, everything will be getting condensation, and because these oculars are internal, you'll have to keep on calling in the engineers, changing the optics from time to time. So it is not, once you're making your refractive unit, you call it as a refractive laser room rather than anything else.
Okay. Dr. Mehta, do you have any questions?
It's very important that the laser room does not, you cannot do any kind of fumigation, you can't do anything for the laser. If you are spraying anything or anything of that kind, you cannot be. So what he's saying is very important. The temperature and the humidity will have to be maintained very well for your femtosecond laser and your excimer laser. But you cannot have any kind of chemicals being spilled over, because it will spoil your laser machine.
Okay. We move on to our final speaker, Dr. Senthil, an innovative thinker who understands that innovation in medicine, like technology, manufacturing, management, are very important, along with the clinical and surgical skills. Dr. Senthil has co-founded WellCare Health Systems Private Limited and was selected as one of India's 50 most promising startups in India in the Smart CEO event. And we are thrilled to have him join with us to speak on team building, the pillar of your career. Over to you, sir.
Yeah, thank you, young IARSI, Dr. Rohan Mehra, and everybody on the panel for inviting me for this interesting session. The previous two speakers did a lot of explanation about the physical infrastructure needed. But whatever building and whatever OT we set up, I think most important is to have the people working in. I remember I was talking to Dr. Mohan, who runs the Mohan Diabetes Centers. I met him around 6 years back. He said, I have a lot of people who are willing to give me money to set up 100 diabetes centers. But he said, it's very difficult for me to set up because I don't have diabetologists and trained staff, a good team working in these centers. So money was not an issue even now. I think there are lots of people who are willing to give funding to start even 100 eye hospitals. But where do we get the team? I think that's the most important question we have. And once we have a team, how do we actually use the team as efficiently as possible? So let me start with the famous quote from Henry Ford. He said, you can take my factories, burn my buildings, but give me my people and I'll build a business right back again. So this implies how important it is to have the right team to take our business forward and build our business. So what is the similarity? I see a lot of similarities between a golf player and an ophthalmologist, because both these people are individual players. Golf is a sport where there is not a team, but you compete against individual and you want to compete against other individuals. As an ophthalmologist also, most of the time, a single practitioner, we try to compete against other ophthalmologists, and mostly we are individual players. But on the other hand, to build a successful practice, we need to have a team under us. So we should not be an individual player. Right? That's the most important thing which we have to understand. And over the next 10 minutes, I will not take more than 10 minutes because the previous speakers have also spoken. I think maybe we are running out of time. About what are the essences which we have to create to build that successful team. So let's go back in history. During the age of the Roman wars, I think you would have seen this in a lot of these war movies, olden movies, where they form this formation called the Texudo or tortoise formation. Basically, it's a team which will stick together. Even if one person is weak in this, sometimes this whole thing might collapse. So this implies how important is the team for our organization during right from the time of ancient ages. And this is Buzz Aldrin and Neil Armstrong who landed on the moon. And it was a historical moment in 1962 for all of us to see that men could land on the moon. But there was a team of 300,000 people who worked for almost 2.5 years before these two people were able to land on the moon. So that shows how important is the team which has to back us. This is another example of successful team. These are the forest guards called the black mambas. The black mamba is a snake. Actually, it's a name for a snake in the Kruger National Park in South Africa. This black mamba is a very successful team which guards the park against poachers without any instruments, because they have that coordination and collaboration as a team. So very successful team histories. How do we actually build these teams in our organization? In our organizations, we should have these black mambas, or we should have people who work together to put us on the moon. So how do we build this team? So the basic crux is managing business in India is nothing but managing people. So we can, because it's so much population, 132 crore or 140 crore population, India might even become the next world's most populous country also. So for anything, we have a market. So for anything, I think even for sweets and even for people could build markets out of this drink called Rasna or all these things. So only thing is the market is there. We can set up these institutions for even eye care, but managing that business is about how do we manage people? How do we create the team? How do we create that cohesive team? That's the most important part of team building. So if we understand this, I think most successful businesses are people who can actually manage their teams properly. So let us see, managing is not controlling the team, but how do we actually manage our team? So life is a team sport. With the World Cup football happening, I think everything in life is done as a team. So 2 weeks back in Tamil Nadu, in the rural villages, there is a festival called the Temple Car Festival, because each temple has this vehicle called the temple car. I don't know, I don't have a picture of that. So which is pulled around the village on one particular day every 3 years or 4 years, and the temple car cannot be pulled by a single person. So basically at least 20-30 people or hundreds of people have to join together to pull the temple car around the village. Basically this encourages the team. How do we achieve as a team? So everything is a team, and sport and life is definitely a team sport. I think individually we cannot achieve much. So as an ophthalmologist or even as an entrepreneur, so once the most successful people are people who have built the most successful teams. So at this point also we should drive into our minds right at the beginning when we start our practices also, because in ophthalmology we always have this thing to get carried away that, oh, I am the doctor here, so what is the role of other people? We always feel that we are the most important person in the hospital. There is no doubt about that. But the team which also works with us is equally important. So I think Dr. Mehta, when he started the introduction, he spoke about the successful founders. These are even for a successful founder, you need a co-founder. So these are like Steve Jobs and Steve Wozniak, the Google founders and the founders of Infosys. All of them had a team even in the founding group. So even as individuals, it's difficult to start and succeed in companies. You need to have the team built up right from the founder stage. So other important point I would like to impress is you have to create this trustable team. So this person, Anand Sharma, I met him in, I think, one of the hotels in New York. He worked for the Four Seasons Hotel in New York. So the Four Seasons became a big, what is Four Seasons? Not just because of the brand name, but also people like Anand Sharma working in the Four Seasons Hotel. He also works part-time in the Holiday Inn, but that customer service was not equally good in the same person working in a Holiday Inn could not do the equal customer service. So I asked him, do you like working in the Four Seasons? He said, I not only like working, but I actually love working in the Four Seasons Hotel. So I asked him, what is that which helps you love an organization or an enterprise? So he said, the Four Seasons, and the managers actually come once in a while and they ask, how are you doing and how are you performing? Is there anything we could help you out to do your job better? But on the other hotel where he was working as part-time, the managers were mostly seeing if he's doing work, whether he was present on time. There was a lot of the control. So there was no trust in that other hotel. So the employees don't deliver better when you don't trust them. I think you have to build a team where you can trust them equally, and building the trustable team is the most important part in each organization. So do we really trust our employees? Once we trust them and once they understand that they are being trusted, that is when they will give you the best output as an employee. So trust is the most important factor which we have to develop in our employees team. So we can even see like the customer service in most of our hospitals, the employees don't really work with that involvement. Let's say a receptionist sitting on the counter, maybe she doesn't treat the patient well, or you can even try to call your hospitals. How many of the hospitals' phone calls are being answered? So the people don't work properly because they feel that they're being monitored. They just nobody trusts them. I think building the trust in employees and building a team which you can trust is the most important crux in team building. So the other point which we always feel as an ophthalmologist or a doctor running an organization, we want to be the smartest person in the organization. We want to be the smartest. So let's say a senior ophthalmologist appoints another junior ophthalmologist. He always feels that he needs to be better than the junior person. There's nothing wrong. The senior always has a better skill in terms of surgical expertise and other things. But it should not be that you should be the smartest person in a room. Basically, let's say a Wipro, Asim Premji, he started Wipro, but he didn't know anything about softwares. So he was actually running a sunflower factory, oil factory before he started Wipro. But he had the smartness to have people who were smarter with them, smarter than him, and he was able to extract the work from him and build. Let me not say extract. He was able to get work done. He was able to build an organization by employing people who are more smarter than him. So I think we should let out this ego that we should be the smartest person in our hospital. We should get a lot of different talents into our team. Having more smarter people in our organization definitely helps building that successful team. So another important point is basically you should be both a microbiologist and an astronomer. So what a microbiologist has is a closer view of things happening in the organization. And what an astronomer does is they look at the further horizons. Astronomer always has this futuristic vision. So if you have to be a good leader, if you have to want to control, manage your team, I think you should be both a microbiologist who understands about the problems of each employee, understands what the employee needs, understand how they are being treated, how they work, and how they are progressing in the organization. And on the other hand, you should also have a long-term vision for both the organization and the team working for you. So having this knowledge of expertise of both, having the ground level view and the futuristic vision is important when you are trying to build that successful team which will take your organization to the next level. Another problem which we have is always we want to get the credit for what is being done. I think we should never mind who gets the credit. Whatever we have to focus is the work should be done. I think that's the most important thing. Even if another employee or another doctor or other partner working gets the credit, we should not be worried about it. So people also want that credit to be for them. I think if you don't mind who gets the credit and let focus only on the work being done, that is one of the most important crux for team building also. So I think when Dr. Rohan started, he said about incentives. Everybody needs money. Money is definitely important, but at the long term, people don't work only for money. People also want to have a lot of other things. People want to work in organizations which are empathetic towards them, not sympathetic. Organizations which show empathy towards them. Organizations which recognize them. Organizations which help them grow. Organization which has a future for them. Your team has to see that they have a future working with you for the next 10 years, 15 years, and 20 years. So it's just not increasing salaries. It's just not incentivizing, which will help you build the team. But it is also looking into finer aspects of employees, their families, and their requirements, which will also help you build that good team for your organization. So I would like to thank you for the opportunity. I have a very small presentation, so maybe I thought we can have more discussions on this particular aspect. And thank you, IARSI, the Young Ophthalmologist team of IARSI, and these are my contact information. So if you need any more details, please feel free to get in touch. Thank you.
Thank you so much, sir. Thank you so much. What I wanted to ask you is, sir, what about group practice? We are seeing that this group practice pattern is coming up. How would you recommend that people around would sort of get into group practice, and how does one handle the finances in that, sir?
So basically, there are group practice, though everybody feels excited about group practice and everybody wants to be a part of a group practice, but there are very few successful group practices in India. Basically, Indian doctors, I think, want to be more individualistic, and then everybody having this equal education kind of creates a problem for being together. I think a group practice group practice is the way to go forward, and that's how things will work in the future with the rising regulations and rising cost of instruments and other things. So basically, I think the most successful group practices I've seen are maybe people who are united not only as ophthalmologists, but also there is some other binding thread with them. Maybe they are from the same college or they are from same institution like Arvind or Shankar Nethralaya, or there is something which is also binding them apart from being an ophthalmologist. And then giving up and maybe forming the right agreement at the initial stages, exit options, and what will happen in the future. I think all those things have to be drafted carefully when somebody is setting up a group practice. They also have to see what are the points of discontent which might arise, and why people will leave the group, and what will be happening to that person who leaves the group. I think if these are all structured properly in the initial stages, but a lot of young ophthalmologists, on the positive note, we see a lot of young ophthalmologists who are now joining, 2-3 people joining together and then setting up a group and becoming very successful. There are some of the good successful models are like Disha, and I think even ASG, though it's a corporate, these are a group of 3-4 doctor friends who join together. There are lots of successful group practices, and basically we need to have that tolerance and maybe some amount of letting go. I think that's the most important thing for a group to succeed. So regarding finance, I think there are lots. I think it's a separate topic in itself. We have to discuss on a long session.
Thank you so much for your talk, sir. It was really, really insightful. We would like to end this session. Thank you so much, everyone. We are so glad to get such pearls of wisdom from our pioneers and from our esteemed speakers. For those who are starting out new and those who are confusion on how to run a practice, I'm sure that this webinar has helped them tremendously. And for those who missed out, definitely it's on our channel, save for the archives. We will see you all next month back for season 2, chapter 4, A to Z of premium IOLs. Thank you, the Microvision team, Mr. Ashok and Mr. Navneet, for all their help at the back end to run this event so smoothly. See you all next month. Thank you, sir.
कोई नहीं मिलेगा।